We took them out of order. So I think we're going to move on to the payer and health system panel now. Ben, if you could give me the mic, I'd like to invite Diane Stewart, the director of the Pacific Business Group on Health, who's going to be leading the payer and health system panel. If we could have the panelists come join us. Amir, Rubin, Betsy, Thompson, Gary Greensweig. I believe Bill Olson is filling in for Jeff Mason, and Michael Kanter. So we will make some extra space up here.
Great. Well, it's been an amazing day, and this panel we've heard about what the opportunity is to improve care for Californians, and all of the things that we can do to take advantage of that opportunity. We're going to try and move now from the what can we do to the how that we do it, and we've heard that the what's to improve blood pressure control and stroke prevention aren't necessarily rocket science. But the how to do it reliably everywhere in California might be approaching rocket science. So I'm very grateful for this panel to be willing to step up here and with me try and tackle that question. I'm going to introduce our panel myself. I'm Diane Stewart, I'm Senior Director of the Pacific Business Group on Health, responsible for paying for value and care redesign. And immediately to my left is Betsy Thompson, Chief Medical Officer at our own Region 9 CMS. And then we have Michael Kanter from the Southern California Kaiser. And then we have Amir Rubin, who is our host today. He's the CEO of the Stanford Hospital and Clinics. And very happy to have him today. And then I think we have our new ad. No? There's one more in the middle. Gary Greensweig, who is the Chief Physician Executive. For Dignity Health. Okay, thank you. And then our late ad is from United. Yes.
Olson, and I'm here for Jeff Mason. He didn't tell me it was a roundtable, so I was all prepared to come up and speak for a couple of seconds.
Well, thank you for joining us at the last minute. Okay, I'm just going to make a couple comments to frame our question to the group today, and then we'll pass the microphone to each of you for about 5 minutes, and then maybe we'll come back and see if we can have a discussion with coming up with a way forward. So as I mentioned, we heard a lot about what we can do. It's really how do we do it and make it happen in a uniform way across California, which is the challenge. As I was sitting here listening, and I did a quick back of the envelope calculation on the number of Californians we have to reach to meet our goal of 80% with hypertension control. So we're at 69% now. If we get to 80% as a state, which is above the 90th percentile, we have to reach 700,000 Californians. And that actually works out to be almost 2% of the entire state of California. So daunting goal, but I think we can do it. The other is to administer TPA within 60 minutes, let's say. And I tried to calculate how many neurons that would save, and my calculator ran out of zeros. So maybe Amy, you can help us with that. But I couldn't come up with the impact. So let's say we were to set those as stretch goals. Let's say in 3 years, just to get the creative juices flowing. What would it take to reach another 700,000 Californians and get them in hypertension control and administer TPA within 60 minutes as an average across the state of California? So that, if we were to set those as goals, and let's just right now assume we're within the HMO product line where you think payment was at least not in conflict with what we're trying to do, but still tough. So if we set those as goals, what would be the most important collective actions for us to take? We have a unique combination of people here in the room between plans and researchers and purchasers and providers. What would be the most important collective actions to take? And then how could you or your organization contribute to that way forward? So I welcome a volunteer. Maybe I go first.
I'm closest to the microphone, so. Can you all hear me? Is that okay? Boy, tough question, especially because listening to all of you and the reports out from the groups, it's so clear that healthcare really is local, and here I sit, from a national, large bureaucratic agency. But I think I'd go back, to what Arnie started out with, I think, earlier in the day, and again, this may reflect my sort of national population level perspective, but one of them is really reducing that unwarranted variation and just looking for variation anywhere you see it. And when it's, there is a certain amount of variation that's perhaps even desirable, but not, it isn't avoidable, but there is a level at which it really is unwarranted and needs to be reduced. And the other thing that he talked about was intensifying the care and thinking more about like intensive outpatient, the outpatient intensive care unit or that kind of model, and just doing everything we can. So I think I'd probably really push on anything in your own local system that addresses those two issues at the heart in the way that needs to be there. And that may be very different in San Diego than it is in Sacramento, than it is in Los Angeles, as we heard everything. Apparently Los Angeles has its own unique set of issues, which is not too surprising. So I think that's what I'd say in terms of what you'd focus on. Do you want me to go ahead and talk about what my agency or what we can do now, or do you want to?
Sure, yeah, go ahead. Yeah.
Again, this is probably a little different response than you're going to hear from the other panelists because of what CMS is. I know when I worked at another federal agency, we used to talk about CMS being the 600-pound gorilla in the room, and why didn't it act like a purchaser, and blah, 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 because it could really drive change so dramatically. Well, having been at CMS now for 4 years, I understand how difficult it is. It's like turning an ocean liner, or actually make that a huge mega cargo ship, as opposed to, some of you are in systems that are more like a nimble, yacht, or maybe even some of you are little, the ski jet things. Turn on but the thing is when we do make a change, it is like the 600-pound gorilla. It is massive with a lot of impact. So I think that, you've seen what we focused on. Janet Wright did a good, real quick overview of the things we're doing that I think have to do with alignment. It's alignment of incentives and with outcomes. It's alignment of measures across different programs. It's alignment across payers is what we're all pushing for, and hopefully we'll see some of that through the panel. If I have some time later, I might come back and talk about some of the current efforts that you're not as familiar with. I think you're all probably familiar with ACOs, but maybe less familiar with some of the work we've been doing with our innovation awards and with the comprehensive primary care initiative, but I'll stop there.
Okay. So I'm going to put my name tag up here. I'm from Kaiser Permanente, Michael Kanter. Obviously, this is a challenging issue here, and if any one of us knew exactly what to do, we wouldn't be here. We would be finished with this project and moving on to something else. To me, I think I sort of look at it as two things to do. One is within our own delivery systems, what can we do, and then what can we do within the community and collectively. And to me, this is the first thing, it's to create actual systems of care and not rely on individual heroics, hiring, everybody can hire above average doctors and pharmacists and healthcare workers. It doesn't work when you do it statewide. And so you really need systems of care. And I don't think there's any one system. Dr. Milstein mentioned a few thoughts earlier this morning about systems. I'd refer people, we just published something called Complete Care, which is sort of the Kaiser Southern California system. It's in the Joint Commission Journal on Patient Safety in the last issue. I can give a nice talk in 3 hours. It's a really good talk, but I won't do that. So I would suggest read it for your pleasure. But the key concept is it actually doesn't matter what the disease you're working on, whether it's cardiovascular, stroke, or COPD, or diabetes, or anything. There's certain key elements in a system that need to work. So you're going to have an element of patient outreach, patient education, guideline creation, titration algorithms, medication adherence, all of these things you do for anything. So if you can set up an infrastructure that will manage those processes of care, you can just plug in any disease. I think that's really how I would think as a state, if everybody could figure out how to do that in their own system, we could make a lot of traction. So I'm a big systems fan. I think internally a couple of things though. We found our hypertension control rates from around 2004 to current went from around 54% to about 87, 88%. So huge increase there. We did not change our governance, our infrastructure. It was all by creating these systems in place. So those of you who think you'll magically form an ACO and align incentives and do a little P for P, to me it's the systems that work. One thing I wanted to emphasize that I haven't heard, because we're talking about HEDIS measures, but we put a lot of focus on hypertension identification. And I would submit that may be more important than control rates. And we found while our control rates went up about 30%, we went from 400,000 hypertensive patients identified to 670,000. So if we ignore the identification and just focus on control, I think we're missing the boat. Smoking cessation I didn't hear a lot about. I used to be very impressed with ourselves because our prevalence rate's about a little over 9%. And then I started thinking, that's still an awful lot of people smoking out there. And so we need to put in more efforts here in terms of robust programs that'll help people stop. I wanted to talk about things we can do outside of our deliverables collectively or with the community. And one key one that's been mentioned is a patient education for stroke, acute stroke. That's something we can't do with the delivery system ourselves. We need help, and I suspect everyone else needs help. If we can work together and put together a robust educational tool for the population at large, I think we'll all be incredibly better served. So I think with that I will stop. I guess we're just going this.
I think that's what we have.
Great. Well, first of all, exciting to be here. Thank you, Diane, for throwing that softball. That's an easy question to start the group from. It was really exciting to hear the report outs from the group. Maybe just following along Dr. Kanter a little bit, just thinking from the Stanford health system, I would say most of our direct challenges are how we structure workflow and processes. And there really aren't that many ideological challenges. It's not that anybody doesn't want to do anything. It's how are people's days organized? What's their workflow organized? What are the systems that are in place to help achieve those goals? So we're on our lean, if you will, journey. We'll never arrive. But a lot of our effort is around designing processes of care that can achieve outcomes. And wherever we've engaged physicians, team members, clinicians in working on processes, bringing the data, and then I think the key thing is then designing the work to sustain it. It always works. Whenever we just say, hey, here's some good ideas, nobody ever refutes like any of the information here, but they don't know what to do with it afterwards. Well, yeah, but I have these 30 patients I need to see. What do you want me to do? So I think maybe collaborative type approaches like A Million Hearts or or IHI types or other states have done collaboratives. We've done collaboratives in our states on other conditions. Can be maybe good ways that multiple organizations can go through a joint performance improvement effort and talk about how does one then redesign the role. So who's supposed to look at these metrics in the clinic? How often do I look at it? Is it a staff member? Is it the physician? Is it a health coach? Where does the data come from? That's where I find things get hung up. And if we can help folks solve those specific problems, people want to do a good job and find the outcome. are able to happen.
Good afternoon. My name is Gary Greensweig, and I really appreciate being here. I work for Dignity Health, and I want to just talk about how we've approached this, which I think may be helpful. Before I do that, I just want to go back to two things. One is having to do with the guidelines, and I think it was mentioned this morning by the gentleman from Kaiser in Southern California about the importance of the emergency department. We talked about this at lunch in the emergency department physicians. There is clear reticence across the national community on the part of ED physicians. In some segments, maybe not at all, but I really do think that's a focus that we should take, and I think that we should take that at a state and national level, not just on a physician-by-physician level. The other thing is we've talked a lot about stroke identification and being sure that patients understand those symptoms, but I really also think we need to focus more upstream. Diabetes, high cholesterol, smoking, hypertension, the obvious things, that there's fertile ground there. And frankly, talking to somebody about their symptoms as it relates to stroke is too late. We need to be talking to them about what gets them to the table, if I may say. So I wanted to spend a minute and talk about Dignity Health in the context of how it relates to this discussion. Dignity Health has 40 hospitals. It's the 5th largest health system in the United States. And these hospitals are mainly in California, Arizona, and Nevada. And we are, frankly, a context of national health care where 10% of our physicians, about 10%, which is 1,000 out of 10,000, are in an integrated model, much of like what we've talked about today. But the other 9,000 are not in an integrated model. And frankly, those 9,000 physicians are who are caring for the majority of patients in this state and in this country. And I think one of the first things Hattie said this morning is, gee, our IPAs aren't performing very well when you look at the quality metrics. I'm not picking on the IPAs, but the issue is that IPAs are really not technically integrated enough to make this happen. And so we have embarked upon a strategy that we think will help get us there. We've actually embarked upon 2 strategies that I want to talk about. The first is called creating a clinically integrated network. It is different than an IPA in that it is a group of physicians that come together. They join a club, if you will. The basis of the club is not utilization management. It's quality and quality data. We create the information systems and the management systems so that these physicians can pick their data, the PQRI data, and all of those related things, core measures and the like, and share them, and then the network helps manage that data. So when you have physicians who are in individual practices, small groups, out in the community, but you expect them, we expect them, to achieve results similar to what we've seen today, we need to have a way to link them together in a way that works. We now have 2,300 physicians out of our 10,000 clinically integrated networks across the states of Arizona, Nevada, and California. And these physicians are now assembling their data. We have websites where it'll get published. We have management committees at each level and quality management committees that will go back to the physicians and say, gee, you're not doing very well on hypertension. So I think it is a model that we certainly are pursuing as a way to reach out to independent physicians and patients who see those physicians in the community. The second thing that I want to mention is that I think this is a long process. And if you think about it, most of the physicians in the world live in the old pay-for-volume model. And what I want to say about that is most of the people that we train do also. So we have residents across the country in community hospitals, integrated models, university models. But think about it. How many of those institutions have integrated their trainees into the national healthcare movement, into the change of pay for volume to pay for value? And so one of the things that I think, and sort of my second recommendation, is we really need to look at who we train and how we're training them, what we're telling them, and what we're asking them to do. We talked a lot today about physicians leading teams. For those of you who have residencies at your facilities, how many of you have trained your physicians to lead teams of ancillary providers? I don't see hands now, maybe that we don't have residents, but it's an important question. And so I think that as we look both at primary care physicians and specialty physicians, their roles are changing, and I'm not sure that we've prepared them to make their way into the future. The last comment that I want to make is that I think that there are great examples. The IOCP project from Pacific Business Group on Health is sort of that bridge to getting people in the community towards medical homes. It speaks to care managers, care providers, health coaches, all of those things that I think extend what primary physicians do in a medical home model. And so I think that we need to really focus on that as a way of moving the system forward and creating what is really value versus quantity.
I'm Bill Olson. I'm with United Healthcare, and Dr. Mason handed me his notes and asked me to present them to you. So, and I notice I'm a little nervous. I think the last time I sat next to a dean, I was trying to explain why I shouldn't go on probation. Oh, thank you. United Healthcare has two projects going on. I'll tell you briefly about them, and then I'll answer the easy question, as the man said, the softball that was lobbed our way. In Southern California, we have a project going with a consortium of school districts called VIVA. They, in conjunction with Ralph's, are doing a study of intense management of patients that have diabetes, type 2 diabetes. They had hoped to have 100 patients in it. Unfortunately, they were not able to get that. They have roughly high 30s in it. And they're worried as that project is coming to completion if they'll have enough power to say whether they're going to get results or not. That one's being done in Southern California. By the way, I have to mention that's done with Monarch and Glenn Goldis is gone now. And today at lunch, and this is great news, Scott Flynn has offered to join that, and Arch Health Partners is coming in as part of another project that we have too, which is trying to manage hypertension in patients using intensive pharmacy intervention by the pharmacist. And you heard a little bit about that earlier. In Northern California, of course, it's Dr. Arevalos and Sutter Independent Physicians is doing the project, and that is without embedded pharmacists. The other one in Orange County is being done with 2 embedded pharmacists, so we have much bigger numbers going into the hypertension project to see what kind of success we can have by having those pharmacists involved in the care. I think this is a very important direction, and I will now answer your question. I think we're already doing the most important thing, and that is we are starting to integrate the care. We need to push it as fast and as effectively as we can do that, because I think once we start aligning incentives and we can bring the pharmacists on board and they're being incentivized to help make the population get well, then, and we're of course doing that with the hospitals, we're doing it with the hospital chains, and we're doing it with the individual physicians and the medical groups. The faster that we move forward in this direction, I think the more success we're going to have, because we're all trying to achieve the same objective, as opposed to turn the crank and do the volume. And with that, I'll hand it off to the dean.
Thank you, everybody. Unless Steve would like to. That was great perspective. I have a couple questions for the panel, if you'd be. And first of all, thank you for your bravery for being up here and taking a swing at the softball. I may open it for the audience here in a second. I wonder if you could comment on potentially, because you've all mentioned the intimacy of changing work processes and working with people to work differently, and that's intensely local. It's very intimate work, really. And are there things we can do collectively that help you as leaders on those efforts? Be the big guy who helps can take the message to the people about the importance of change. And I don't know if you can comment on the role of measurement. Hattie, we started the day with what the measures were and how people were doing. And I know that CMS is getting more into measurement. I'm guessing that many of you use measurement within your own organizations to help facilitate that change. So I'd love to hear you talk. Maybe I'll pause there and invite anyone to talk about the role of measurement, both external and internal, to accelerating the change. Yeah, go ahead.
Well, I think a couple of points. I think following up on Amir, your comments, not only are most of the physicians not necessarily in integrated groups, most of the patients are not in HMO plans, and in California, outside of Kaiser, or certainly at least in Northern California, HMO is shrinking because of the move towards self-insured plans and trying to manage the regulatory requirements or get around the regulatory requirements. We see a lot of large employers going there. So I think, the other question is back on data, and we're doing the same in our organization as well. My joke is if somebody has, really full-blown PPO insurance, should we not manage their diabetes or their blood pressure? Or, of course we should. And so I think that's an interesting question. We have, from our IPA, we have claims data, we're using EMR data, but I think there's, a data question, and I think external groups, just as, NCQA with HEDIS measures and IHA and these measures have helped us on kind of the HMO side. What should we be measuring? And a lot of it would be the same measures, but sometimes if you're not the primary care physician for that patient, but maybe you end up being the endocrinologist or cardiologist, should you measure nothing? Are you not accountable? Or do you have to be the whole network? And again, a lot of healthcare is in distributed forms. For ourselves at Stanford, we have some integration and some distributed. We have some of our own primary care and distributed network, and we're also a referral center for other cases. So I think that's an interesting data question, one that we're working on.
Okay, thank you. Yeah.
So a couple things. You mentioned something about all care being local, but I think we have a regional office and then roughly 200 medical office buildings. I think there is some work that can actually be moved centrally and doesn't have to be physically in the primary care physician's office, particularly with changes in technology, and that becomes tricky when to do local versus more centralized. But I think measurement is one of the things that is best done centrally and on a larger scale for obvious economies of scale. To me, measurement is key. I think there's two reasons to measure. One is for accountability, so you can have either P4P programs or publicly reported HEDIS measures that presumably allows people to compare to each other. That's to me more of an accountability type measurement. There's a performance improvement measurement where you want rapid data coming back either weekly or monthly, depending on what you're doing, to improve your processes. And I think without that, you can't really create a robust system of improvement. So I'm sort of a big data hound and love data, and you can get too much of it, but I don't think we're there yet. If we get the right data, it's key, and a lot of the value, in my view, of the electronic medical record is it allows us to actually become more of a learning organization, and it's, I think that's about all I'll say, but there needs to be a national data strategy. I would add that we have limitations when we can't share from one organization to another, and the patients go in and out of our system, and I'm sure they go in and out of everyone else's system. We need some kind of interoperability on our electronic records desperately.
Betsy,
Just to follow up to related concepts, I think one thing you said that was key, Michael, is you need the right data. I mean, I spent over 10 years as a health services researcher. I love data, but I believe that we often collect data that we have no use for. And we collect data sometimes because it's the data we can collect. And there may be a time and a place for that if it's all you have. But in general, I would just really push all of you that are in the business or have some say over what does get collected, make sure you really are measuring something that matters, because all of us, I think, have probably been guilty of doing the opposite of that. So that was one thought, and I think the other thought I had just went out of my head at the end of the day. I wanted to come back to it's sort of about all healthcare is local, and just mention that a little bit more about the Comprehensive Primary Care Initiative. How many of you in this room know about our Comprehensive Primary Care Initiative? Okay, so several of you do. I think it does start to help with with some of the issues that IPAs might have. What we did, we actually funded this project in 7 market areas. No one in California, no area of California is included. The insurers first had to apply to us, and we had to find areas where there was a large enough proportion, a large enough market share of insurers that wanted to play. And then we went out after we picked the 7 market areas and got 75 to 100 practices in each of them. And it really is, you know, we don't have any data yet. This just started up a year ago, but I think it will be very interesting to see. These are very large sort of advanced practice medical homes. Some of them in Colorado, Oregon, and Arkansas, they're statewide. So it's an attempt to move the smaller practices into something more akin to an accountable care organization, but with the idea of moving them along the spectrum to even push them into maybe a capitated type of arrangement, or at least more risk assumption as we move forward over time. So just, you know, keep your antenna up. That's something we might all learn from.
Any other comments on measurement? Okay, yeah, here.
Well, I would just agree. I think there's more data out there than Carter's has pills. And I think that the difficulty with a lot of the data is it comes from claims-based sort of ways of collecting it. I think if you look at hospitals, they have a bunch of folks like ants who go around and kind of get data out of the chart, they extract it for core measures and other sorts of things. And that tends to be the more useful kind of data. So as we move to electronic systems, I'm not certain that we've crossed over the chiasm, if I may say, of extractable data out of electronic medical records in a meaningful way. And I think that is sort of our next chore, is to figure out how we take someone's electronic medical record, which is not standard, it's close, but it's not standard, and get that relevant clinical information out of it. Just the other thing about your question, what can we do? I actually think that the thing that will drive us all the fastest is a change in the way that we're paid. And certainly that's coming. It's part of the Accountable Care Act. It's part of what everyone is doing, but that really drives, I think, will drive a change in performance. And in the interim, some focus on pilot projects, on startups, exactly what PBGH is doing around this particular project. I think those help people make the move for their patient populations.
Diane did not meet with
Oh, yeah, it was not picked up.
Right. Well, one other question about what might accelerate change. We talked about measurement. And then what about technical assistance or collaborative learning as a way to accelerate change in California? The California Quality Collaborative, which many people here in the room are part of. We have the Regional University of Best Practices as part of the Right Care Initiative. Do you see a future for that as a way to more quickly improve care around hypertension control and administration of TPA?
I'll start since I have the microphone.
Yeah.
I think those things are really good. If you go into the community and you find a medical practice, primary care practice that's got 3 doctors in it, and you say to them, who would like to go to this conference for 3 days and learn all about how to take care of primary care, how to take care of hypertension, and come back and teach it to the rest of us, you may not have lots of folks who want to do that. So I think as we create these larger models like clinically integrated networks, that's an opportunity to, at that level, to bring those learnings out there.
Any other comments on that? And let me open it up to the audience, either questions to the panel, or if you were to say what's required in California in 3 years to reach 700,000 patients and improve their blood pressure control, or get the average administration of TPA to the right patients in 60 minutes. What do we need to do collectively to make that happen, let's say in 3 years? Good ideas out there in the audience we need to bring forward? Yeah, right here, Jim. Jim Middle. Yeah.
I'm going to suggest that we're missing a metric in hypertension, and that is you're not interested in hypertension, you're interested in decreasing complications of hypertension. And when you look at them, they're greater than 80% cardiovascular. And because everybody is focused on blood pressure, if you just open that up, use Archimedes' model, wherever Don is here, and you look at the impact of adding things that work on cardiovascular disease rather than blood pressure, you'll find that statins and aspirin to a smaller degree equal the benefit you can get. And it happens quickly, within a year. So if you want to double the benefit on the hypertensive patient, you may just add a statin at each visit. So, but I'll ask Dean, why don't we look at cardiovascular disease? When we didn't look at it in cholesterol, it took us 5 to 6 years, when we did look at it, it took us 5 to 6 years to realize just working on cholesterol, the way we were doing it wasn't getting us anywhere. And when we went to the high-risk people and bundled the disease, in 2 years it helped.
Well, I think that's a question for the panel to respond to. Yeah, and others in the room as well. I don't treat patients, Jim. I just philosophize over them.
I mean, I'll take a stab at this because I think you're correct. What we want to prevent is complications from cardiovascular disease. And if somebody has high blood pressure and they don't get any complications, I would say they might be happier that way than if we try and treat them with a bunch of drugs. So I don't personally look at what is I look at what our hypertension control rate is, but I think one has to look at every single risk factor in every single patient, what's modifiable, what's not modifiable. Certainly there's good data on aspirin. I think one of the challenges is a measurement issue of do we really know who's taking aspirin because it's over the counter without a prescription. But it's certainly something that I think we need to work on. I suspect with natural language processing in our EMRs, we might be able to do a better job of capturing that perhaps. Statins is another great observation. So it's multifactorial, all those things, and we keep forgetting smoking because I think HEDIS may be driving us more than it should. And what we're not really measuring too well is disease prevention because it's harder to measure than measuring a standardized HEDIS metric. And I did mention we're totally ignoring the unidentified hypertensive patient.
So we do have John Morris with us from Archimedes to address Jim Duddle's question about statins, and didn't you mention something about 400,000 lives, Jim?
Yeah, sure. I actually modeled this for the nation. It's staggeringly impactful, but that's not.
Jim probably has the numbers better than I do, but I'll just say I'm completely aligned with, particularly with statins. Well, everything we've looked at, since there's not much harm to treating people with low LDLs, it suggests that there's a lot of opportunity to treat people further with statins in particular, and prevent a lot of them. In fact, probably our estimate is outside of ATP3 that there are people who could be treated who have as much potential for risk reduction as the people that we aren't catching within ATP3, and equally cost effective. Actually, if I might add just one thing, where Archimedes is working with the NCQA. We're beginning field testing. They're beginning field testing of an electronic performance measure that calculates reduction in risk as opposed to counting people who are treated to target.
That's really interesting, actually. Yeah, very interesting. Yeah.
I just wanted to piggyback on Jim's comment just about we're not treating hypertension, we're trying to prevent complications of hypertension. And as one of the major recipients of the complications of hypertension, the patients don't know that their hypertension is going to cause a stroke. So I think that's a very big deal. I don't take my antihypertensives because I don't feel bad. I'm fine, why should I take this? And it's a blood pressure medicine, I'm not sick. So I think changing the dialogue for the patient as well as for ourselves.
Can we return to collective action? Oh, well, yeah, Liz.
Sure, and to add to that, which is really a great comment, is that when patients come to the physician's office, they're usually presenting with something else that they need to talk about. So what's the time frame and what's the complex chronic conditions that may be also underlying into out of control high blood pressure, and how do we change that conversation?
That's a great question. Yes, Molly?
Just a point of clarification, under ACA, aspirin is now a covered benefit if the physician writes a prescription, so we will be able to look at fills.
Great, I hear lots of debate on the clinical aspects and not so much about how we change the state. Neil?
Yeah, I mean, I view us going in a headlong rush in opposite directions. We're rushing toward these aggregated population-based systems, accountable care organizations, and simultaneously we're running in the opposite direction, doing more PPO medicine. That market's growing. Certain things in the tax structure of ACA are pushing large and now smaller groups in that direction. I think we have to think about both. I think we can't just think about one or the other. On the PPO side, where I've spent not that much time, but recently had to struggle with it, one thing I actually learned from you, Jim, more than a decade ago, is to focus on point-of-care reminders for physicians, not panel management. But when the patient's going to be showing up, if you can get them the data in real time when the person's coming anyway, you can make a huge difference because it's not a lot of extra machinery to then do the outreach to the patients. They're there in front of you already, and you can do a couple quick things and make a big difference. So you can deal with all the cardiovascular risk things in a quick check off the boxes kind of way. So I think that maybe that is the single biggest intervention for cardiovascular risk management on the PPO side. The other thing that might be helpful is if we can come up with some strategies for PPO docs to actually have the blood pressure number. It's so much harder than having, say, a hemoglobin A1C, which is a lab test. It's so much harder to track the numbers if they don't have an electronic health record or some other way to do it. So at Blue Shield, we're starting to look at ways to try to help the PPO doctors. On the HMO side, that rush toward more population-oriented medicine, I think, is moving toward more and more hospitals acquiring or partnering with very large medical groups. And I think that the resources are really going to need to come to some degree from the deepest pockets there, which are the hospitals, in order to be able to, with the exception of Kaiser Permanente, in order to be able to deliver the kinds of population data to the physicians and the non-physicians who can really do panel management more effectively than individual docs in their offices. Those would be the strategies I would suggest.
Great suggestions. Yeah, any comments from the panel? And then we'll wrap it up.
I'm not sure this quite gets to what you were trying to get us to talk about in terms of collective action, but it's been mentioned that there hasn't been a lot said about smoking, but I've heard really nothing about physical activity and nutrition. And if you look at the data, compared to statins, compared to anything, the data are there that this is probably the single best thing we could do if we knew how to do it. But it strikes me as we talk in this room that we're a bunch of medical folks. We know a lot about how to deliver health care. We know a lot less about how to improve health. And I think that that's where we really need, there are some fairly decent data that at the community level you really can move some of those health risk behaviors. So I just want to put in a plug because we haven't mentioned that yet.
Yeah, that's true. We've discussed that very well. Yeah, Michael?
Yeah, a couple. I mean, that's a great point because we measure BMI on all of our patients. The good news is it's actually dropped the last couple of years. Not by a massive amount, but any drop is good. Initially, we thought it was we're bringing in all the 26-year-olds from Obamacare, but when we took them out, it still dropped a little. But I think that I'd like to compliment the lunch had a minimal amount of desserts and junk food here. So I think part of it is actually leading by example and modeling the right behaviors as healthcare professionals in terms of what we eat and how we exercise. I wanted to make a point on the point of care work, because I think this is huge, but when patients come into the office and they've got cardiovascular risk factors, I think we delegate all of this to the primary care doctor. In fact, when you actually look at the statistics, at least within our system, 2/3 of the patients coming in with a modifiable cardiovascular risk factor are seen in specialty care, and maybe they need an A1C or an LDL test. Should specialists be talking about weight reduction? I mean, I actually find a huge opportunity with orthopedic surgeons and patients with osteoarthritis that probably should be losing weight. And there's a whole host of diseases specialists take care of that would benefit from weight reduction. And I think as a profession, we really haven't leveraged our specialty care networks and tend to over-rely on primary care and then panel management. I don't think they can do it by themselves.
Okay. I think we're just about at the end of our time. So again, thank you to our panel for taking on the rocket science.